Good morning, good afternoon, and good evening, everyone. My name is Malik Ismail, and I'm the founder of Global Spark and a consultant at the Boston Consulting Group, who is also on secondment at Google X, Alphabet's Moonshot Factory. I have the absolute pleasure today to welcome all of you to the 2021 Global Spark Thought Leader Panel. We have a brilliant set of panelists, and we're extremely excited to have all of you here from across more than 40 countries for what I think will be a really inspiring and an insightful discussion. Now, before we begin, I wanted to take a few moments to introduce you to Global Spark, who we are, what we do, and why we do it. And then I'll hand it over to a couple of our sponsors to share a few words, after which, of course, we'll hear from the panelists. So for those of you who are meeting us for the first time, Global Spark is an education nonprofit that is run by young professionals and student leaders from around the world. And the reason why I started Global Spark in 2017 was because we found that most students aren't exposed enough to the cross-disciplinary thinking and collaboration that's needed to tackle our world's most pressing problems. On top of that, we found that many young leaders weren't sure how to navigate solving these problems while also pursuing their careers. There seemed to be this belief that you could either have a for-profit career or pursue social impact, but that the two didn't intersect. And so as Global Spark, what we aim to do is to push these young leaders to not only think about how they can influence the world, but how they can work with others across disciplines and backgrounds to do so effectively. Now, the way that Global Spark does this is we partner with universities, corporations, and nonprofit organizations around the world to provide unique, often first of their kind learning opportunities for students and young professionals, where they're exposed to the latest cutting edge thinking. In particular, we do this through four main programs. So we have our annual Global Thought Leader panel, which you're all attending today. We also organize Hack the Globe, which is Canada's first multidisciplinary social impact hackathon, where we incubate social enterprises tackling the UN Sustainable Development Goals. We also partner with many universities around the world, and over the past 4 years, we've built curriculum for over 120 courses, where we teach students how they can apply each of their skill sets to some of these pressing global challenges. And then finally, we partner with several local nonprofits and student organizations to run local events and design challenges. Now, of course, none of this would be possible without some of our amazing partners from across disciplines and around the world, two of which are here today and you'll hear from shortly. With that, I'll hand it over to Elif, who can give a bit more of an overview of today's panel and why we do it.
Thanks, Malik. Hi, everyone. I'm Elif, and I am a PhD student in operations research at Cornell University and a co-founder of this panel. Today, we are really excited to bring to you a unique, multidisciplinary conversation about global health. As highlighted by the pandemic, global health has many urgent problems that need to be addressed. Solving these problems will require creativity, innovation, and collaboration. New technologies will play a key role in addressing these challenges, but their successful deployment requires context-specific solutions. To highlight the importance of multidisciplinary problem solving and collaboration, we are bringing together global leaders with experience in NGOs, tech, business, and academia. We are really excited to be sharing today's panel with hundreds of participants from more than 40 countries. We hope that you take 3 key lessons away from today's conversation. The first is, we hope that you learn about the current state of global health and the key challenges of the next 10 to 20 years. The second is we hope to inspire you with the role that innovation can play in addressing these challenges. And lastly, we want to highlight that effectively addressing these challenges requires multidisciplinary approaches in designing context-specific solutions. Now, over to the wonderful Kate Banting, Head of Social Impact and Marketing for BCG Canada, to say a few words.
Elif and Malik. On behalf of BCG, we would also like to welcome everyone here today. BCG has been sponsoring and working with Global Spark for the last 3 years and are continually inspired by what the next generation of leaders can and are doing. At BCG, we believe in the potential of all people and our ability to unlock that potential. BCG is a pioneer of business strategy, and today we continue to enable our clients to capture the greatest opportunities through digital innovation, data-informed decision-making, and diverse perspectives to spark change. By bringing together the brightest minds, we face tough problems with tenacity and creativity. To succeed now more than ever, organizations must blend digital and human capabilities. At BCG, we work with global leaders in the private, not-for-profit, and public sector to drive meaningful change and impact. Giving back has always been part of our DNA. Globally and locally, we have supported charities, foundations, and not-for-profits for decades, in Canada as well as around the world. Today, social impact is our fastest growing capability as we continue to extend that support to our corporate clients. In 2019 alone, we completed over 700 social impact cases, and I believe that number is even higher for the year 2020. We've worked with over 50% of our largest clients to help them become better global citizens. The problems our world faces today are bigger and much more complex than any one group can tackle on their own, and thus the increased importance of cross-sectoral, cross-functional collaboration. Thank you everybody for coming here today. Thank you for our incredible panelists. I hope you will find some inspiration and ideas and the types of roles that you can play to drive change and impact in the world. I'll now turn it over to Joe Wong, the VP of International at the University of Toronto.
Terrific. Thank you so much, Kate, and thank you, Alif and Malik, for continuing to lead this just terrific initiative. The topic of today's panel, Innovation in Global Health, could not come at a better time, frankly. I think that COVID and the global pandemic has exposed for us just not only the paucity of innovation in some areas, but the imperative for continued innovation in a global landscape. I say it couldn't have come at a better time because in many ways we're seeing the pandemic play out in real time and exposing for us a lot of vulnerabilities around the world. One of the things that we know about the COVID virus, of course, is that everyone is vulnerable, but we also know that vulnerability is uneven and it's experienced unevenly around the world. We also know, as we've seen, the really rapid development of vaccines, as well as the distribution of vaccine, that innovation, for instance, whether it be at the lab bench or in terms of distribution and public policy, innovation is in high drive. But it's also the case that science is unfolding in real time and in full display, and this is leading to new challenges in terms of communications and effective comms, things that we'd probably not thought of before. And we also see, and as a political scientist, of course, this warms my heart to see the role of public policy is more important, I think, than ever before. When we look around and we look at how different governments and different countries and jurisdictions have handled the pandemic, a lot of it is owable, in fact, to differences in public policy. But we also know that public policy is more political and more politicized than ever before. Look no further than questions around vaccine nationalism and the distribution challenges there. So I can't imagine a better panel than the one that the organizers of Global Spark have put together today. Global Spark, as Malik and Alif have already pointed out, is multidisciplinary. Again, as a professor who works with engineers and folks in the management school and so forth, it warms my heart. But it's also global in scope. And I think that this is an incredible opportunity for young leaders around the world to be engaged in the kinds of conversations that we will see ensue in this panel. So thank you again on behalf of the University of Toronto. And now I want to turn it to Alif, Catherine, and Julia, who will introduce our panel. Thank you.
Thanks, Joe. So we're Catherine and Julia, two of the panel organizers, and we're incredibly excited to introduce today's panelists. Our first panelist, Dr. Andrew Trister, is a physician scientist who leads digital health innovation at the Bill and Melinda Gates Foundation. His team focuses on leveraging mobile technology and data systems to enable high-quality healthcare solutions in resource-limited settings. Prior to joining the foundation, he led clinical research and machine learning efforts for health special projects at Apple. Before Apple, Dr. Trister was the senior physician at Sage BioNetworks. Our second panelist, Dr. Maureen Lewis, is the CEO and founder of Aceso Global and has spent over 25 years advising government and private sector leaders around the world on health system reforms. Dr. Lewis has held a variety of management and leadership positions in global health, including serving as the chief economist for human development at the World Bank. She is the author of over 80 publications and working papers, including 5 books. She is also a member of the Council on Foreign Relations, among numerous other international organizations.
Our third panelist, Jim Larson, is a managing director and partner at BCG and is a core member of BCG's healthcare and social impact practices. He leads the firm's partnership with the Bill and Melinda Gates Foundation, with whom he has worked with for over 10 years, contributing to over 60 projects across nearly all their global programs. During his time at BCG, Jim has worked in the Mumbai, Seattle, and Washington, D.C. offices, and has led a number of efforts engaging the private sector on global health topics, particularly on the impact of digital and global health. Finally, our moderator is Natasha Walji, who is a director at Google Canada, leading telecom, tech, and public sector. Previously, she was a McKinsey consultant and a software developer. Natasha was named one of Canada's top 100 most powerful women by WXN and has actively served the community for over 20 years. She currently serves on the board of Ronald McDonald House Canada. So, Natasha, I'll hand it over to you.
Thank you, Julia, and welcome everyone. I am just so delighted to be your moderator today. As you can see, we have a brilliant panel in store for you and a thought-provoking discussion ahead. Welcome to all of you joining from all over the world. I think this is a very timely and important discussion in innovation for public health. And again, welcome to our esteemed panelists, Andrew, Jim, and Maureen. Thank you so much for being with us today. So let's dive in. I wanted to start with a question around your journey for each of you. So can you give us a sense of your journey to today and what has inspired your journey? And I'll have Andrew kick us off if that's okay.
Thanks, Natasha, and thanks so much for the opportunity to join the panel, to the organizers. So I had a very winding road here. So as you heard from my background, I'm a physician scientist. That basically meant that I couldn't make a decision about whether I wanted to be a doctor and practice or do science. So I did both. In medical school, I really enjoyed the opportunity to take care of patients, to learn not just the way that we apply science to care for people, but really the humanity that's involved. And then in the lab, I was really interested in ways that we could augment and level up the care and the quality that we were able to provide. And that extended into the work when I was in practice here in Seattle as a radiation oncologist, to reach out to communities that were less served, not those that are in our backyard. And from that effort and listening to the stories of families, of the patients, trying to understand ways that we may be able to build a more holistic health system here in a high-income country, it dawned on me that there was a lot of disparity that digital could potentially reduce, at least barriers to access to care, as well as allowing a person to have agency in the decision-making. And within oncology in general, there was a consensus in the last 10 years around shared decision-making, where a patient and their family could have greater access to information and allow that to change the dialogue with their physicians. And I realized that this was, in fact, at the very core of what I liked about medicine. It was the idea of trying to bring forward some tools that allowed an individual to ultimately to make better decisions and to have better care. And so that led us to build out a number of tools that ultimately led me to Apple to try to do that at a large scale. And after 3 years and realizing quite a few large scale studies, I wanted to find a path to deploy. So rather than just looking at clinical research, finding ways to translate that into applications is really the core of my innovation team at the Gates Foundation. So the opportunity over the last year and a half, primarily to focus on COVID in this last 365 days, almost to the day, we have found ways to do this implementation research, which is very different than my background, but certainly having much greater impact. And so hopefully we'll be able to talk about that a little more on the panel.
Thank you, Andrew. And maybe Maureen, you can chime in now, and then Jim.
Thank you. Yes, thank you very much for this invitation. This is a great idea. I think Spark is really something that students should be benefiting from and doing widely. So thank you for inviting me, and delighted to be here. So I came at this from a very different perspective. I'm an economist by training, and I was always fascinated by the world. I had grown up outside the United States. And the thing about health is that it's so complicated and it's so interesting and has so many different dimensions. It's one about helping people, but it's about clinical care. It's about management. It's about how can you make things work better? How can you do things more effectively? How can you make patients stay healthy? It's complicated. It's got multiple layers, and that complexity totally attracted me. I worked in other sectors. I worked in education quite a lot. I worked in transportation. I worked in urban. I worked in a lot of areas. And the thing about health is it brings together a lot of different kinds of skills, and you meet a lot of different kinds of people. Problems are different. And I found that I could do more and have more of an impact in health than the other sectors that I had worked in. And one of the things I think about the digital revolution, which is really what it is that it is transforming healthcare worldwide, and it will continue to do so. And one of the things about global health, which is largely about low and middle income countries, is that the digital is already there doing other things, but not necessarily in healthcare. And that, I think, is really the turning point now for digital. And for integrating digital with everything else, because as Andrew said, there are different dimensions of it, and you use it in different ways. And I think this is now the opportunity to take this forward and do this in a more comprehensive way, and harnessing a whole lot of creativity, because there's a lot out there already, and there's a lot that needs to be harnessed, pulled together, and made whole. So that's the challenge for all of us, but also for all of you, because this is just starting. So thank you very much. I look forward to further discussion.
Great, and thank you as well for the opportunity to be here. As noted, Jim Larson with BCG. My road is less winding than, Andrew sort of described his as a winding road. Mine's been relatively straight. I actually started at BCG straight out of undergrad and thought that I would be, at BCG and in management consulting for 2 years or 3 years and then go do something else. And I knew going into BCG that I really wanted to have tremendous impact in low and middle income countries, and in particular related to health. And so thought that I would get the skills and then go move on and apply them somewhere else. And I have found two big differences from that initial hypothesis. The first is that my skills were not done after 2 or 3 years. They continue absolutely to I continue to have tremendous opportunity to learn and grow. And then the opportunity to have impact on global health has been much greater than I thought it would be within the context of BCG. And so really thrilled to get to play the role that I do in our team, with the Gates Foundation, and also more generally in our work in global health now. Natasha, you asked about what inspires me. I am tremendously inspired by the impact that has happened over the past, call it the Millennium Development Goal era. Under 5 mortality dropping by half in low and middle income countries. I'm tremendously inspired by that. I'm also tremendously motivated by the work that remains, and the significant work that remains. The fact that still, a mother in childbirth has a 50 times greater chance of dying if she gives birth in Nigeria than if she gives birth in the US, where I live. And so I'm tremendously inspired and motivated to keep up that trajectory of progress.
Thank you so much, Andrew, Jim, and Maureen. Those are really thoughtful insights, and you can see how each of you are deeply inspired and took very different paths in public health, but are strongly oriented to impact. And we're just so delighted again to have the 3 of you here. Now, I wanted to shift gears a little bit into the context within which we're living. So we're in the middle of a global pandemic, and that's affected the entire world. I would love your perspective, all of you, and what you see are the gaps and opportunities in public health that have been amplified by COVID-19. So I'm going to start with Jim, then we'll go to Maureen, and then Andrew.
Sure, and indeed, this is a good place to start, Natasha. It'd be hard not to start a global health panel, without talking about COVID. So glad that we're starting there. I think that I really like how you asked it, in that there are the challenges and the opportunities, and I think we're seeing certainly both of those. And maybe I'll start just with access to technologies, access to novel technologies, and thinking in particular about access to the vaccine. That has been a challenge for access to novel vaccines. We'll just leave it there. Has been a challenge, for decades in the time that I've worked on global public health. And a good result, would be a 3-year lag between, patients getting the vaccine at scale in the global north or in high-income countries, and patients getting the vaccine, really initial doses, much less at scale, in low middle income countries. And that was a good result. And now one of the great things about COVID, one of the positive things, is it's really bringing a light to that inequity, and real frustration, and moral outrage around the gap in time that people have access, based on where they live, and their broader circumstances, access to this life-saving and sort of life back to normal creating technology. I would say so. That challenge has been highlighted. I would say that the good thing is that I think this has created a really different paradigm. While 3 years was a good result before, now we're looking at the possibility of 6 months or so. Again, I'm not saying there isn't work to still be done, but I think that's a tremendous push forward. And I think we've also seen, just as the consciousness has gone up, late last year, the 15 biopharma CEOs and Bill and Melinda Gates signed a joint statement talking about how everyone deserves access to a COVID vaccine and therapeutic, and that they had a joint commitment to doing everything in their power to ensuring that happened at the same time. And we won't be quite, literally the same day, but I think we are making tremendous progress in that direction. And then I'll just add one other thing. So that's on delivery of technologies. I'll just add one other point, which is I think that COVID, just on the opportunity side, COVID, of course, creates, we now recognize the importance of health, and in particular, global health security, and how disruptive a pandemic can be for health, and just for the overall functioning of our society. And my hope is that energy around global health security will really come to solidify this year into really concrete actions for the global community, and in particular in ways that don't just protect us from the next pandemic, but also really give us the opportunity to serve, to improve, day-to-day healthcare delivery, even before the next pandemic, which we hope is a long way out. And so in particular, I'm excited to see, or really hopeful that there will be a complete step change in. One example is surveillance capabilities, disease surveillance capabilities in sub-Saharan Africa, where those capabilities are relatively limited today. We recognize that those are critical, not just to protect against the next pandemic, and frankly, in the later stages of where we're headed with COVID, but also will be really helpful for sub-Saharan African countries in delivering against day-to-day health issues.
Maureen?
Yeah, hi. Yes, so the COVID has been devastating, as everyone has noted. And I think that the light at the end of the tunnel has been the vaccine, which has come so rapidly. I personally did not believe it could happen. We've been looking for a vaccine against malaria for absolutely decades, and nothing has really worked. So this was quite a remarkable achievement. And the fact that it is spreading as fast as it is has a great deal to do with commitments of the Bill and Melinda Gates Foundation, of WHO, of the World Bank, of Gavi, of major organizations that have really made a push. So I think that's important. Second, I think something that that came out of the COVID-19 is telehealth. Telehealth is revolutionizing healthcare worldwide. And that's true in Rwanda. It's true throughout Latin America. It's true in Canada. It's true in the United States. It did in a matter of months what had taken years of controversy to never come to agreement about. There was a view that this was low quality, that you couldn't monitor it, that you couldn't pay for it effectively, so it wouldn't be done. And it just took the world by storm. And that is not going to go away. And what that has done is it's made the digital part of healthcare so critically clear. Because one of the things that countries that had a digital infrastructure to communicate with its citizens, they could provide cash transfer programs, which has a big impact on health and on obviously on well-being. Those that didn't had devastation among parts of the country where they couldn't reach people because they couldn't help them. So this has been really important, and it will have a profound effect in organizations, philanthropies, and donors and multilateral development banks are going to play a big role in making that more normal, to be part of the system. But that means changing the way you do things. So I think one of the problems in global health is that how you deliver services matters enormously. How you pay for it matters enormously. The digital component is there too, because you can pay digitally, you can get data digitally, but we don't. Surveillance. There's good surveillance in some countries where they completely failed. Brazil is probably the best example. It is the poster child for WHO in Latin America for public health. It collapsed, and it has a digital infrastructure. So there was a management component there. There was an inability to translate things that they do well into something meaningful. This happened in the US, it happened in Europe. So the COVID basically told the world, you don't know really what you're doing very well. You don't have good enough surveillance systems. You don't have good enough systems to track what's going on. And low and middle income countries suffer even more. And frankly, the region that was devastated by COVID is Latin America. Africa was not particularly hard hit outside of South Africa, but Latin America's systems really showed that they really didn't know. They didn't have the systems that they needed to cope with the sophistication of the issues that they had to deal with, the expectation of citizens, or the integrated system that they should have. So I think this is a big issue on how systems are structured, how they're paid for, how they're delivered, and how that digital piece fits together. And that's why this is such a multisectoral sector, because the clinicians, the physicians, those people who deliver care need a support structure to do the work that they do, to do it well, and to reach the patients that they need in a way that patients can respond and benefit. And that sounds easy. And it is on paper, but when you try to implement it, it's not so easy. And I will close by an observation that I think points this up. Every OECD country, Europe, Japan, Australia, US, Canada, Korea, all have different healthcare systems. No one's are the same. So it tells you something about healthcare, its complexity, and how there are problems and challenges that are on the table. At the same time, you can learn from all the different systems because they all know something different. So I think that there are definitely challenges, gaps, and opportunities here, and they are persistent, and we are going towards solving some of them. And I think Jim pointed that out really effectively, but there's a whole big agenda that we really need to pick up and run with, and COVID made that all very clear. So thank you.
Yeah, it's hard to follow Jim and Maureen on this topic, but I would like to pull on this thread that Maureen is discussing with respect to a slightly different lens applied to the same topic, and that is the limitations of data alone, and how is it that data translates to action. And I think that what we've seen is historically the separation between public health, and that is true broadly, not just in global health, and physicians. And I think that this question that Maureen raises actually goes back, unfortunately, to a historic element in the US, to the Flexner Report, which had about a century ago, in fact, was published and had put forward the basis upon which all medical education outside of the British system, so basically all medical education in the world, started to look at science as the core, and that eliminated epidemiology and statistics. So this is where you started to see the schism between the idea of doing public health and the idea of taking care of a patient. Those two things are not independent at all. And what we have seen as one of the major challenges when we're facing such the global pandemic that we have in front of us are that the effector arms of how is it that decisions are made and how is it that the lenses are applied to these data have been completely separate. So the idea of applying policy, as we heard about from Joe in the beginning, seemed to be independent from how is it that we're going to actually deliver care. The last centimeter of putting a vaccine needle into an arm, basically, right? And I think that what we have seen in the global arena is true in high-income countries in the global north, as well as in the global south or in low and middle-income countries alike. And that is that this schism has become a canyon, really, in ways that the data infrastructure can support care for individuals and also the decision-making at the level of policymakers and ministries of health. That challenge, though, comes down to individual problems, right? The broader recognition that we are all on this mortal coil together is an important thing, right? So just as Jim was saying, this is truly global. And I think for a lot of people in the global north who may have previously just thought, whatever goes on in Africa or South Asia will never affect us here. Perhaps now there's this concept of no longer having this like colonialism toward medicine and approaching how is it that we can help communities support themselves because it's in everybody's best interest to do so. I'm hopeful that will be the residual that comes out of this. Certainly that's been a lot of the conversations we've had in the last year. But certainly we haven't seen action in that matter, at least not from some of the previous global leaders in this space, like the US government. So as there's a shift in policies, I do think that that's one of the areas where we can start to lean in. And coming back to this topic on digital, one of the areas, certainly we should talk about vaccine delivery. That is absolutely the bright star of all of the innovations that have gone on in the past year and all of the work that preceded, in fact, for the last decade to lead us to the idea of even having mRNA vaccines. Though, truthfully, those are not going to be the ones that have the impact in the global south. Nevertheless, the concept that we even get vaccines at all in this speed cannot be overstated. Where we have focused has been on this idea of the surveillance system and how is it that an individual who presents and wants to have a test, either in the health system or for public health surveillance or for return to economic activity, like crossing a border, trying to carry goods, travel, is there a infrastructure that will support that person gaining access to that information on their own to give them their own agency while also benefiting more generally the society in which they live? So part of this is gaining access to the test to begin with. So many of the tests that have been used in the earliest days of this pandemic were PCR based. Those are quite expensive. The infrastructure doesn't really exist in places like sub-Saharan Africa to do these broadly. As if any of you have had a test of this sort, the sample collection itself is not the easiest, right? Because it's a pretty long cotton swab that goes through the nose all the way to the back of the throat. Not the most comfortable thing. Usually had to do with the health provider who then was put at risk because people gag or cough. And so all of the shortages that we saw in the earliest days that continue now, things like PPE, access to those swabs, access to the kits to run the PCR, transport, these things sound mundane. And indeed, it's kind of strange to talk about the fact that we do digital health innovation, and yet the first half of this last year spent on COVID, we were very focused on how can we get a swab to people that they can do a sampling themselves, and can we prove that that's equivalent to a healthcare provider collected swab? That required a lot of study. There's a lot of clinical study for that, but as an innovation, it turns out that, again, coming back to this concept of agency for individuals, the more that you can distribute to the person themselves to allow them to choose to do things in a different way than they may have done before, we have found that that is at the core of what ultimately will be, again, we hope, a residual effect of all of this. The idea of a healthcare delivery system that puts the person at the center, that is not pushed down, into the global south from the global north, but truly allows an individual to make decisions. And ultimately, the connective tissue of that is the infrastructure that is all now digital, right? It's not just the data; it's the insights and the actions that get taken from those data that matter. And so, in the end, if you have a person who can, swab their own nose, either give that back to a health provider in the community or in a pharmacy in a locale where they live to be tested and have a return of results quickly enough so that they can take an action that's meaningful, that is a major, major shift that has a ton of potential. Once COVID, hopefully we get out of this in the next year, then we can start to look at diseases like malaria, like tuberculosis, like HIV, with very much the same lens. And so that democratizes access in a different way. It's not just telemedicine, which absolutely has just as Maureen was mentioning, a really, really important cornerstone role, but it's also what is it that an individual can do on their own behalf that informs the rest of the system.
That's great. That was such a rich perspective from all of you. Thank you so much for sharing that. I think when I think about what you just shared in terms of gaps and opportunities, the gaps that I would synthesize are really the inequity that we're seeing across global public health, weakness in infrastructure and in operations. And the last piece was really about decision making. And then I think about the opportunities that many of you touched on, which really have to do with, Andrew, you touched on it, person-centered care, a multidisciplinary approach, unlocking technology, and then thinking about public and the public sector and private sector interaction, how we can collaborate there. So I want to go a little bit deeper on the opportunity areas to see how we can maybe think about that in addressing the gaps that you highlighted. So I thought we could start first with technology. As all of you look ahead for the next, call it 10 to 15 years, what do you see as key digital opportunities that will help democratize affordable and high quality healthcare? And I'm going to start with Jim on this one, and then we'll go to Maureen and Andrew.
Well, I'll start with a pretty basic statement, which I think everyone would just naturally agree with, but I'll put a little data behind it. Digital will be a critical part of delivering on the needs that we have here. And just to help to conceptualize how big that need is, if we look ahead to the aspiration that the global community set out in the Sustainable Development Goals and hitting the under 5 and neonatal mortality ones, just to take two kind of more composite measures, we are on track to miss those by about half. So if you take the gap where from 2015 to 2030, we'll make it halfway to where we wanted to. And in order to make it all the way, we would need to more or less double the value for money that we're getting out of the money and inputs that we put into a system, and then what we're getting out in terms of outcomes. And in many ways, digital is made to do this, right? It's made to reduce the resources that are required. We see in many examples of a 90% reduction in the resources required if you can move to a AI-enabled plus telehealth response versus a typical sort of physician interaction. So we see that. We see greater accessibility, which is another aspect that we need to see, and then we see greater quality. The algorithm-based kind of decision support is as good as the best medical resident in the world, and even better when we think of radiology applications. And so I think it's fit to purpose for that. And again, I'm sort of saying what I think we probably all believe, but just setting a bit of the bounds around it. And then maybe I'll share one particularly. I expect that Maureen or Andrew will want to talk some about the kind of specific use cases that may be patient-facing, and a range of those use cases. I want to talk a little bit more about a use case that I think people think less about, and that is the power of digital to enable just good operational excellence of a health system. You know, a topic that we've been, you know, kind of working at for a very long time, and frankly have had relatively little progress on if we look at kind of an overall level. And so, you know, I'm really energized by this, by the ability for digital to help to shift that equation, getting more towards that 2x value for money, just by driving operational excellence. And one example of that is work that that our team in India had the opportunity to support, was really driven by the Rajasthan government in India. And you know, Rajasthan was relatively low in the rankings of state performance around a whole bunch of the primary healthcare measures. And what they felt and what we found through diagnostic with them was that a big piece of this was just a lack of understanding of where you know, where the performance really of each part of the state against you know, some of the key outcomes, but also some of the key drivers that get you to those outcomes. And so while there was strong desire to have impact, there just wasn't the set of information and decision tools to enable that work, and frankly also to enable some accountability as well. And so what we were able to do is work with them to basically, you know, do fairly basic or maybe use you know, relatively sophisticated technology, but to get to a fairly basic thing, which is just having the set of data that you need with one source of truth, and then using that to create, to have them create what would be most useful for them from a scorecard standpoint, and their ability to say, here's what I would really want to know to be able to manage performance, you know, as it moves up to the top of the state. And that ended up, that primary intervention, which was, you know, again, just adding technology to something that we want to do anyway, right? Which is just manage the performance of workers and systems. That simple intervention was core to creating, you know, a shift in kind of 23% in medicine availability, you know, shifting the antenatal care coverage by 22 percentage points. You know, we saw immunization coverage rise by 10 percentage points, right, from a high base of, you know, 80 or so to 90. So which are just tremendous jumps, and makes me really optimistic about, you know, the value and the power and potential of digital to help on operational excellence, in addition to the broader range of use cases.
Okay, so I think that I want to pick up something that was said before about infrastructure. And the infrastructure is sometimes there. The number of people who have cell phones in low and middle income countries is phenomenally high. And in some countries, it reaches close to 90%. That is not used for health very much. So getting in touch with patients and being able to communicate with them is an opportunity. And again, this telehealth sort of culture may help to change that. So I think that that's very important. And there are data in many systems where they're collecting information, but no one is using it. And we have lots of data that is unused and not operable. So it's looking at different things and talking to different parts of the health system. And as we talked about, the health system is so diverse that creates particular problems. So one, getting data, the right data, and focus on the right things, and getting it used at the management level within ministries of health, but also within the private sector, becomes really important. And the private sector has taken this on much more aggressively. And we see some really interesting things. In Indonesia, for example, there are digital services that help doctors talk to each other and talk to patients, that has just changed the way that the system is run. And it allows them to know what's going on in the system, because you don't really always appreciate the fact that there are data out there, but if no one's using them, then you don't know what's happening, right? You don't even know what's happening with your patients. And so that's an issue. And in South Africa, they've done some really interesting things with sending out nurses into very low income areas, and they're basically entrepreneurs, and they use digital, and that makes them able to run their business very inexpensively and to communicate with patients. And those kinds of things I think are really important. Something else that's quite related is, and this is something that Natasha mentioned in passing, and that is the public and private systems. They are separate. And again, one of the things about COVID, it made it clear that they had to start talking to each other, because the public sector often, as they are referred to in India, that the private sector are bloodsuckers, which is a pretty strong statement. But you hear things like that all over the world. The public sector feels that the private sector cannot do anything and cannot do anything well. And that has really broken apart with COVID, because they've needed the private sector to meet the limitations of their system and of the impact on the entire country. So that interaction, again, the best way that they can talk to each other, pay for services, can coordinate for the patient, is through digital solutions. And so there, I think, again, there's real potential that is untapped, because there have been two separate systems. So within the public system, you have multiple sources of information, one for surveillance, one for public health, one for clinical care, one for something else. And that fragmentation needs to be addressed. And as they start working with the private sector more, and that is starting to happen partly because of social insurance, using digital and information from digital information generators, and IA for that matter, will allow you to do a lot more in terms of integrating the system, both in terms of the public and private, but also integrating for the patient. Because the patient with an electronic record can go many places. And right now, if they go to the private sector, they might have some information. If they go to the public sector, they might have some information. But that needs to be built up, both generally, and because one of the things that is happening worldwide is that what we call non-communicable diseases, chronic diseases, are becoming a big deal. Diabetes is one of the fastest growing diseases in the world. And you have to monitor people with that. HIV, same thing. You need to monitor patients to see how they're doing, to have them come in periodically to be tested. Same thing with diabetes. And so the digital aspect of healthcare becomes enormously important, because that allows it to happen. But I will end with what I started with. But then there have to be systematic ways of using the data, integrating it, and acting upon it. And that remains a weak link at the moment, but there's lots of potential. And we saw this all come around with telehealth. So I'm very optimistic. Thank you.
So just as with the last question, this one's very provocative, because in the next 15 years, it's a hard, really, really hard time horizon to think about, because things, just as Jim was saying, we are in this exponential phase of the sigmoid, especially with adoption of digital tools in general. And I think, to Maureen's point, we have other purposes that are driving the adoption generally. So this isn't a thing that, people are choosing, even those who are living on $2 or $4 a day are choosing to have some access. Like that's a commercial choice, right? A consumer choice. And so it's as the SDGs have highlighted, right? Digital and these tools become a right. Access is important, but it becomes a question of what are the services that can be built on top of that backbone. And I agree. I think in the 15 years that are coming, we're going to see a revolution in terms of individuals having control of their own information and plugging into a system that can use that information on their behalf in a way that actually reduces costs. One of the unsaid things about technologies in medicine, is an unfortunate truth, and that is the fact that in almost all systems, whether they're capitated or fee-for-service, like in the US, technologies tend to drive costs up. So this isn't something where we tend to, it's like a one-way ratchet. You don't, and I'm not the economist, so Maureen, it'd be great to chat about this a little bit, but we haven't seen technologies get to that point that Jim's talking about with respect to improving algorithmic decision support or improving the workflows to bring efficiencies that actually start to reduce costs and improve care, the unicorn that everyone is chasing with respect to digital health. Part of that, I think, relates directly to what it is that Jim's talking about, because we just haven't looked at the system-wide implementations of these. And a lot of it is what Maureen already mentioned, which is the fact that many of these systems are siloed, that there's this friction across, no interoperability between data. And I would say that there's an opportunity in this time, although it's a very, and this is very much like standing on the edge of a knife on this, because it can fall in a different direction. But if we were to agree as a global community that individuals should have the control and agency for their own data, you move away from the model that has existed to date when you implement digital tools in the health system, right? The whole concept of an EHR right now is that the health system will protect the data generated by its doctors, not on behalf of the patient, but on behalf of the doctor, right? And in the US, that's for billing purposes, and maybe in some other systems too. But as Maureen mentioned, many of the OECD countries have different health systems. So it's not necessarily for that. If we can shift that dialogue to, say, for individuals themselves who are seeking care or who are being seen in a campaign, that data goes back to them and it's theirs. And they can choose to share it. If they can find value in it, that's private or public sector, they can bring it. And so the terminology that we've been using on this lacks some things, but we think more of a personal health record rather than an electronic health record to try to make this distinction. But at the end of the day, all of the necessary infrastructure needs to be there. You have to have a health system that knows what to even do with this data, right? So the AI components, the idea of being able to do decision support. What do you do if you're not able to carry around a smartphone, right? So do you still have access to these things? Do they exist ethereally somewhere in a proverbial cloud or blockchain or fog, whatever you want to call it? Do these things, like how do you prove that that person is actually tied to that data? And do they still assert control over that is a major, major question. And I think, again, just as we talked about in the last question regarding COVID, that's precisely the kind of thing that has been accelerated because of COVID, because we're starting to see the implementation of vaccine passports as an example. So how is it that you certify that you had a vaccine or a certified test result, right? So in Europe, test results that, had a certificate attached to it were being sold on eBay. So you can go and travel if you had quote unquote proof of having a COVID test, rather than just going and getting the test directly. They were going for 30 euros to just get this certificate. In India is the largest at scale vaccine certification program that uses digital. And it's been quite a success. So 14 million vaccine certificates have been deployed. That's over 99% of the vaccines delivered to India as of 3 days ago, and which is quite impressive, because even with the digital divide, the system that has been put in place still mints an individual QR code that a person can have on a piece of paper that ties back to the system in a way that that pulls it through. I think as you see more personal adoption of tools that connect people, we'll start to understand more about how this very, very specific use case of, let me just give you a QR code that proves that you had a vaccine, moves into what additional information is necessary to actually deliver better care and get to those operational excellent points that Jim was raising earlier. We'll start to understand if you can just carry around your data wherever you're touching the health system, be it a druggist, a community health worker in the public sector, or a level 3 hospital, it won't matter, because you're still in control and you're able to bring those things around. I'm very certain that we'll have that in 15 years. The questions are going to be, though, whether there's going to be other market forces or other regulatory forces that are going to impede the progress that we've already seen around COVID. And so that's where I say, like, it's very tenuous to go out there on a limb for what's going to happen in past a decade, but I'm quite hopeful that that's where we're going to end up seeing things going.
Thank you, Andrew, and thank you, Jim and Maureen. So I'm going to touch on one topic that Maureen, you started to touch on a little bit here, which is, what do you see as the role of public and private sectors in the emerging and developing markets as it relates to public health? And I'll have Maureen and Jim touch on this question, and then I have another question for you, Andrew, in a minute. Maureen, do you want to take us away? I think you're on mute.
Yes, thank you. Yes, this is an issue that I think is really important, because if we look at some of the poorest people in the world, they go to the private sector. There's a public sector there, but they don't use it. And when they do use it, they try to make it work for them, and it's very hard because, quite frankly, most health systems are built by and for doctors. And I know Andrew will agree with me about that. Certainly, in many countries of the world, and moving away from that is difficult. I have a little bit of an anecdote on the electronic health record, which I think is relevant to this public-private. In India and also in Mexico City, you will, if you go to a hospital, there are people standing around waiting at labs and at x-rays. And they've already been diagnosed, but they want their records because they don't think that they don't trust the public sector to retain those records and have them for the next time. They take them home. So there's already in some parts of the world a realization that they need to have test results so they don't have to have them repeated. One of the things you find in the public sector is they repeat tests because there's so much gap between when the test is taken and when somebody looks at the results and evaluates it for the patient is too long and they have to repeat them. So this is very common. And in the private sector, it doesn't happen as often because there's a much more of a client mentality as opposed to a patient mentality that makes it, that is not patient-centered. And patient-centeredness can be very difficult because when you're trying to run a health system or a hospital or even a management practice, it's really hard because you have so many demands that come from so many different directions. So I think that that's one issue that is not going to go away. So it's a really big challenge. However, the private sector provides a lot of care in a lot of different kinds of ways. In the last decade, the public sectors in a few countries have realized that if they don't use the private sector, they can't reach the poorest people because TB has been treated in the private sector far more than in the public sector because they've found providers who were willing to take them on and to evaluate them. They're also in areas that often aren't served by government clinics. And so in India, they now have a system where they reimburse the people who notify, because what they used to do was the private sector would notify the government that they found a TB case, and then the government would say, oh, okay, well, we're going to take care of that patient. And so the private sector said, well, why should we do that? If we can't treat the patient, then why should we even notify you? So they didn't. So this has been an evolution. Same thing in Pakistan, same thing in Nigeria. And it sort of points up the importance of the private sector because the private sector is many things. It is a guy who runs a motorcycle, who has a motorcycle, who takes lab results from the lab to the patient or to the physician to advise the patient. It's the people who take the drugs and deliver them to public clinics. Public clinics are chronically short of drugs. They run out of them. Why? There's a public distribution system. The OECD doesn't use public distribution systems for the most part because the government, that's not something government does well. This goes back to the public policy issue. Government does policy, it can do programs, but it doesn't do delivery, logistics and delivery particularly well. And if we all we need to look at is the distribution of COVID. You know, it's FedEx who took the lead on that because the government knew that it couldn't do it in the United States, and that's who has been in charge. So I think that the role of the private sector is very large. It's often ignored. It's often not measured, and we don't look at what patients do, because if we want to be patient-centered and we look at what patients do, they go to the private sector more often than public, especially in low-income countries and especially low-income people, and the highest end. The highest end people often have health insurance and they go to the private sector. So there's this tension, there's an opportunity, and again, COVID has played that up. So I've been a little bit wide-ranging in this, but I think these kinds of issues are what are going to define how we go forward and how we try to use both the public and private sectors and implicitly force some sort of defragmentation so that patients can move within the system. And it goes back to some of Andrew's points about having some kind of a record that individuals have access to. And India is making great progress on this, only in inpatient care, but for some of the poorest people through a social health insurance. So we could talk a lot about this. There's a lot going on, but I think there's lots of potential here. And I think that, again, COVID has played that up, and it's one of the benefits of COVID. So thanks very much.
Thanks, Maureen. Jim?
Sure, and love that, Maureen. And I think the I will also spend the bulk of my time, but you're talking about private sector in large part. I think Maureen highlighted that it needs to be public and private, noted that that there is real wariness associated with the private sector, real misunderstanding of the private sector, and as a result, private sector gets way less focus, time, attention, and less than would be optimal for delivering the results that patients want. And so my prior example of operational excellence, that was all public sector, and now I will just focus a little bit on private sector, recognizing they need to complement, but it will focus on private sector. And I think, this is where, just to tie back to our prior technology conversation, I think there's just such an opportunity for technology to help break through some of the challenges here. And I think there is I think it is a fair concern from public sector parts of the concern of public sector operators are fair in terms of the ability to monitor and ensure quality in if I take Nigeria for example, over 200,000 PPMVs, little drug shops around the country. Which are a critically important part of the healthcare infrastructure, and I think there are ways to think about improving quality in that context. And so one is certainly digital, and I talked about digital decision support, and that's a place where I see tremendous opportunity, to be able to take someone who has a high school education. Some have high school education, some are actual pharmacists, right? It's a wide group of people, but the ability to enable that person who wants to provide a great service, Maureen's point of they have a service orientation because this is their business. They want to provide a great service to the patients that come to them, and with the power of technology could actually provide an even better service. And so there's real importance on how we actually deliver that in a cost, in a way that works from a cost standpoint and solves some of the business and operating model challenges. But the tech solution is quite clear and compelling. So that's one. And then the other, I think we haven't talked a lot about sort of the biomedical or packaging type innovations as well. But if one of the places that people go to private sector primarily for is acute curative care. The second primary place that people go to private sector for is for family planning. And one of the challenges to family planning to go to the private sectors, particularly in these lower cadre, kind of drug shops, the range of methods that they can provide on a regulatory basis is quite limited. And so there's actually a disparity. Women want to go to the private sector and they're actually not being afforded the set of choices and options that they would optimally have. And so some of them continue to go to the private sector and use something that that is suboptimal for them. And some of them choose to go to a channel that they don't prefer, the public sector, in order to get the method that they prefer. And so we'd love to see this compromise be broken. And one of the primary ways is just innovation. And just to pick one, injectables, intramuscular injectables are in most countries not allowed to be delivered by, the lowest kind of drug shop users. But there's an innovation that the Gates Foundation has funded and others have been involved in that creates a subcutaneous of the kind of DMPA, the primary the primary injectable, and enables subcutaneous injection, which totally shifts the safety profile of the product and can enable lower cadre workers to be able to deliver it safely and effectively. And so it's another example of a way to harness the power of the private sector, through other innovations that enable them to provide the quality services that in this case women are really demanding from the channel that they prefer.
Thank you, Jim and Maureen. Those were great insights. My last question before Q&A is for Andrew. You touched on this quite a lot, Andrew, earlier, which is the need for collaboration across disciplines. And I think this is particularly important when we think about innovating in public health and we think about people-centered care. I'd love your perspective on what do you think we're doing well today and where do we stand to improve?
Yeah, it's a great question, and actually this discussion on private and public sector is a wonderful example of this, because you see that people bring their different expertise to the same problem, and it's only when we hear these different voices that we're able to come to solutions that we can try out. So just as I said in the beginning, in my own meandering path here, I have tried to embody this like multidisciplinary approach in myself. I wouldn't recommend that to anyone. I think that this is like very painful. So instead, what I would say is that we have found that it's only through collaboration with people who think through policy, who understand systems level design, who try to put forward a perspective that relates to the individual person having their own agency, as we talked about. This could be clinicians or others who have touched the health system in that way. Obviously, the more economic focus and the ways that we can bring different incentives, but fundamentally, people who are able to represent the communities in which we want to do our work, so that it is no longer a sense that we can sit in the global north and solve all the world's problems, and if only people would listen to us, then everything would work. But instead, find a way to collaborate with people from different disciplines, but ideally people who have had different experiences. And that could be, again, yourself, like going and trying to suspend your own disbelief and try to just go and learn and talk to people. But I think that this is, there's actually a Wharton professor who just wrote a book called Think Again. So Adam Grant has talked a lot about these ideas of organizational development. And I highly recommend this kind of thinking, that you always be skeptical, right? So is maybe the scientist in me, like we never are looking for the answer. It's always trying to disprove something. And so it drives my team crazy, I will admit, that we go forward with like, particular stakes in the ground, and we try to do things. And then we invite many people to go and to basically tell us why it's not going to work. And in that process, it helps us hone our thinking, but it also allows us an open space to talk about, what is it really that's going on in the world? These are very, very complex problems. And just as Maureen has said early on, healthcare in particular, one of the most complex. And I think that it could be really, really valuable to have people who have passion in whatever it is that they do, right? Engineers, software engineers, like the hackathon that you hear that Global Spark does, people who come from a lens on policy, certainly anyone who comes with a background or interest in doing things like population health management or medicine. Coming together to come up with some solutions and try them out, I think is the only way forward right now. And that means that, truly, like the core of this discussion has been about innovation. Innovations fail. Like this is not going to all succeed. We're not going to see, the world turn over and suddenly everything is going to work. But it's through those failures that we can then pick up and say, maybe there was a little gem in there, like this part did work and other parts we have to keep working on. And not to get discouraged, but to constantly be curious, to try to seek out differing points of view. And as many of the people who are tuning in now are, at a stage in their careers, I understand, in university, going into graduate school, maybe early career days, like take advantage, never lose that. Jim said that in the very beginning. It's like, don't assume that like the 2 to 3 years in the management consulting and you'll have all the answers, right? It's like the curiosity, I think, is going to be the key for an individual to take that forward. But I think in the multidisciplinary way, right, is like surround yourself with people who have different experiences, and that can only lead to to bettering the whatever it is that you're working on in this space. And my hope is, and I said this to the panelists when we got to meet earlier this week, but none of the people who are talking here are going to be the ones who really make all of this work. Like a 15-year timeline, I hope to be still working in this space in 15 years, but in reality, it's the people who are watching, right? So the anonymous attendees here that we see writing Q&A questions. All of you are the ones who are going to make this really, like all the change that we're going to see in the world, it's going to be you to do it, right? So if we can help to clear some path, or at least make that road a little easier, then that's really the role. it's not, you know, and so that's where we welcome collaboration, and we try to really have open arms to people who come with different ideas, rather than pushing back. And so, you know, I hope that you'll find that most of the doors that you push on start to open a little bit, right? And that was one of the other pieces from COVID that just coming back to the very first question we talked about. There were many areas around this public and private sector component around how technologies were getting adopted, ways that, you know, large supranational organizations, the multilaterals, the UN agencies, et cetera, worked, that made it next to impossible to really bring innovation into the world quickly. COVID dropped a lot of those barriers, right? So doors that I couldn't even see suddenly appeared, right? They weren't open, but pushing on them together, like we suddenly got them to crack. So let's keep doing that, right? Let's make sure those doors stay open, you know, for this foreseeable future. Because if we go back to the way that things were working before, just as Jim mentioned, there's no way that the world is going to reach any of the sustainable development goals, and certainly not the ones around health. So I see here as the opportunity that all together we may be able to bring forward something different.
Thanks so much, Andrew. It's such a interesting perspective, and it's really about, from what it sounds like, shifting from multidisciplinary to really interdisciplinary collaboration, which is really about bringing expertise together, understanding what the intersections are, and it's about agility, curiosity, and learning. So thank you so much for highlighting all of that for us. I'm now going to shift gears to Q&A. Thank you for all of the great questions that have come in from across the globe. We're going to try and answer a few of them now. So our first Q&A question is about how do we think about the balance between A, ensuring advancements in health and medicine are available and distributed equitably globally, and B, respecting a local country's culture around what might be perceived as Western medicine and not imposing? Excellent question. I'm going to have Maureen kick us off here, and then to Jim and Andrew after that. Maureen, I think you're on mute.
I'm trying to unmute. It fix.
No problem.
This is a really good question. I think that there are various ways to answer it. You can take a country like India or China, which have very broad types of medical care. And they have Ayurvedic medicine, which is traditional in India. They have Chinese traditional medicine. And what's happened in much of the world is those get merged. They start working together because traditionally they've used certain kinds of procedures, and then they want to continue doing that. But then they see that there's something else. One of the things we find about healthcare is that people use all of them. There was a really interesting study done in New Delhi, India. Over the course of a year, they tracked certain households to see how they use healthcare. They went to shamans, they went to Ayurvedic medicine, they went to the public sector, they went to the formal private sector, they went to their friend next door, they went to somebody who read lab slides, they went to pharmacies, they went to labs, they went to a whole slew because they didn't know. They didn't know where to go, so they used all of them. So in a sense, it gives them options. That's one part of the question. The other part of the question is much of the world, the WHO, for example, has members from all countries. And there is a certain understanding of something about medicine that all countries have embraced. That doesn't mean that every person within those countries have embraced it, or that every country does it the same way. But there's a global standard and people want to reach that standard. Countries want to reach those standards. So there's a little bit of that, but that doesn't mean that the traditional medicine has gone away. You see that in Latin America with outlying Indian groups that continue using their own forms of medication. And what's really interesting is the vast majority of medication has come from Africa and Asia and Latin America because Europe didn't have the range of treatments 400 years ago that they had in those parts of the world. And many of those have become formalized drugs. So I think it's really being merged, and no one is telling any country that they must do one versus the other, but they're part of the world community and they've sort of learned and they're adapting together is, I think, the way I would put it.
Thanks, Maureen. Over to you, Andrew.
Oh, yeah, absolutely. Yeah, I think that on this, Maureen is describing something interesting with respect to consumer choice and going and seeking out care. That just to underline it, it's each of these different practitioners offer a different resolution, right, for an individual. So that there is absolutely a sense that we should be respectful of like what is it that people are looking for, and supporting those solutions in any way that we can. Ultimately, just as the discussion with the private sector versus public sector, this divide, we should also be all encompassing for these various forms of non-allopathic medicine. The questions there are actually even in the Northern Hemisphere, we have exactly the same problems. I mean, all of these they're taught in medical schools here as complementary medicines, even though they are not complementary to the patients who choose to have them. They are primary medicines. And I think that that's the thing to recognize, right? And where historically allopathic medicine has taken a dim view to what the value is of some of the more traditional practices. Therefore, patients have not been as willing to share the fact that they may be having like an Ayurvedic practice. And that has caused actually some really big problems with respect to how the patient would, potentially taking some herb and then have a supplementary allopathic prescription. And so these are things now where increasingly there is a respect for different forms of medicine, and a recognition that being as open as possible for individuals to share that they are following all of these different routines, because as I say, there is something that they're seeking out, that they're gaining from it. And the other part of the question regarding how to ensure equitable access, this is a really tough one. And I would say that at the moment, it's difficult to imagine building a health system that really does have equity. I think that there will be equality in health access through public sector, but we lack a lot of data at the moment to understand where are those who are least able to access, and how is it that we might be able to tilt the system towards those. I think that, again, on the private and public sector, the incentives are much greater for private sector to solve this than public sector at the moment. So largely because of the way that reporting works and some of the other ways that the global development community funds, I'm hopeful that some of those incentives and the incentive structure toward that work actually shifts toward improving equity. But at the moment, it's difficult. So I think that the beginning point has to be just a recognition that there is inequity. Again, COVID has made that obvious. And so we could start to use the data that we have been collecting recently to help to address this, through policy and through some of the other types of financial and other types of social incentives that might exist. But that is a really, really tough part of all of this, particularly when we talk about digital and technologies, right? Because those, like putting those into the world, you don't assume equity immediately.
Great, and love it's I now get where you were, Andrew, in the early questions of answering after two really excellent answers, and so I'll just add one very small point, which is I think one of the keys is we're really only talking about 4 primary large donor streams of funds when we think of global health. There's the Global Fund, which aggregates a bunch of bilateral donor spend. There's Gavi, which is similar for vaccines. There's the World Bank and GFF, and then there is the U.S. government through various bilateral streams. And so those there's actually some benefit to the concentration in that each one of those global donors is at a point on a journey towards more kind of country-led engagement between that global donor and the country. And so I think that is a big piece of this answer, is ensuring greater country ownership of that process to ensure that the countries are the ones who are saying, here's what our citizens care about. Here's what we care about, what our priorities are, and then that is what is sort of the core of the dialogue between them and the global community.
Thank you, Jim, Andrew, and Maureen. Very thoughtful perspectives. Our second question has come in around digital health, and I know that's a passion area for all of you. So the question is, the possibilities unleashed by digital health are very exciting, but for communities which do not have access to stable electricity or in hard to reach areas that cannot easily access maintenance and tech support, etc., how do we ensure the adoption of digital health interventions do not exacerbate inequality and leave these communities behind? So I'd love to start this one with Andrew, if that's okay, and then we'll go to Jim and Maureen after that.
Yeah, so just as the first part of the previous question, this one is quite difficult. I think to this end, at least in our strategy with introducing digital health tools, we have not taken the perspective of the way that we might think about it in the global north, where it's an individual, their own device and using that to gain access. Instead, the main focus for us has been to augment the health workers directly. And so it's a known cadre of workers, who are either on payroll from government or in the private sector or NGO or volunteers, but at least they're known. There have been a number of really large-scale rollouts. Again, we've talked a lot about India, actually. So many of the Western states now you've heard about. So the work that Maureen mentioned in TB, it was in Maharashtra. What Jim talked about in Rajasthan. We worked in Gujarat, which is sort of like right next to those other two states. In Gujarat, there are, and across India, there are a cadre of health workers that augment nurse midwives who live in the community. And in Gujarat, just as of less than a year ago, it's been mandated that they all use a tool that was developed within the state on behalf and with the health workers. It actually is a great example of combining these. But when we have done field studies with them, what we have found is that in the most rural communities out in the Kush and in other parts of the state that do not have connectivity or, to this point many had electricity, but not in every single house. The health workers could still carry the devices into the community, use them to collect information and to have the decision support tools that they needed to best improve the care delivery for pregnant women and newborns, which was really the point of that program. We're right now looking to see if we can expand that to things like non-communicable diseases, as Maureen had mentioned, which even in Gujarat continues to be a big problem in the community. I believe that for many development reasons, we will start to see more electrification, more connectivity going forward. So the concept will have to shift towards individuals having more access on their own, right? In the way that you might think about telemedicine. But for the time being, and likely over the next year or two, the main focus, at least in the innovation that we're trying to bring forward, has been with respect to the health worker themselves, ensuring that their workflows are efficient and that the data that come back from the communities where they're first touching people can be actioned upon most appropriately so that the quality of the care gets elevated. These are two massive questions, and so we're hoping to see some indication that might work.
Yeah, I would just build on the great points from Andrew, just to say first, 100% agree that there's a tech part of this solution, right? Sort of a grid and mobile connectivity, sort of, the way to be able to step away from that, via the health system. So that's number one, fully agree. I think there's also just a recognition of the current state of the challenge and then the trajectory that we're headed on that sort of will make this, on the time scale of innovation that we're talking about. I'm certainly hopeful that we're at a very small fraction of the population for which, even those step away from the grid solutions are required. And so just to give you, the data for Nigeria right now, and this is work that we did related to some geospatial mapping we did to support some financial inclusion work. But the principle holds that if you look at the percentage of people who live within 5 kilometers of a point that would have both electricity and mobile access, that's over 90% in Nigeria as of last year. And that is only going to, to Andrew's point, we're seeing quite a bit of acceleration, quite a bit of focus on solar homes in Nigeria, just to take that as one example. So I think that this will continue. So it's a both. I think there's just recognition that we're talking about relatively small and getting quite small. And so on the time horizon for many of our innovations, expected to be, approaching vanishingly small. And then still in the intermediate time, being in a position to build technology that can step away from the grid.
I'm going to just add a couple of examples to these really good answers to the question. And that is that one of the things that I have found worldwide, I've seen this in Latin America, I've seen this in Africa, I've seen this in Asia as well, and in the Middle East, is that where people don't have connectivity, for example, on the government side to collect data, they collect it and then they go to a spot where they know they can connect, and they upstream the data, and so then it gets reported, and they do this repeatedly. So that's one thing. The second thing is the cell phones have so much value for people across the board that it is being adopted really fast, and they will find ways, just like this example that I just gave, to be able to use that for multiple purposes, and healthcare can piggyback on that. And that it's quite remarkable how many very poor people have a very simple, it's not a smartphone, it's just a very simple phone. They can get text messages, they can pay for things. In a place like Kenya, there's not total coverage, but you have basically people doing the exact same thing. They're going to the places where they can, upload their data, they can download what they need on their phone based on what they can pay bills, they can do all sorts of things. And that is obviously the future. And that's when it becomes very equitable and very much bringing people in who are on the margins, because that's what the power of digital is, I think, for those people.
Thank you. Thank you, Maureen, Andrew, and Jim. So my last question for you before we close here is, we have, as you can see, people dialing in from 40 countries across the world, over 1,000 attendees today. Many of them are super passionate about making a difference in public health. What is the one piece of advice you would say to them for those that want to change the world in this space? So I'm going to start with Jim on this one, and then over to Maureen and Andrew.
I would say, maybe I'll just hit a similar note that I started with in my introduction, is that it's a never stop learning. And that has real implications for how you think about what your first job is and how you approach that job. It's a little bit funny, right, to be saying, as you're getting out of a formal learning environment, to then focus your time and attention on learning next. And I would just say that is it will serve you so well to do that. And I would just one really short anecdote for me. The most that I've ever learned was the year. So I was 11 years into my career. The year after I was elected partner at BCG was the most that the most that I have ever learned. And every year take like a learning inventory to say, what have I learned this year? Like, what am I actually significantly better at? It's almost never sort of formal learning. It's almost always just a mindset and a growth mindset around what can I learn from this, and be in an environment around people who are similarly driven and motivated. And so we just encourage you to have that kind of mindset around formal learning. Moving from formal learning to profession may actually only accelerate the learning, and to have that focus on that aspect.
I will take it from a personal point of view as well, as did Jim, in that I just kept finding things that I like to do, and found things that were interesting and challenging and would make a difference. And I didn't really have a path. I didn't know where I was going. And I've been very, very satisfied with my career. I wouldn't trade it for anything. But I think part of it is get involved, find out what you really love to do. Because when you do what you love to do, it is not work. And you will excel because you like it. And you know, in global health, there's so many dimensions, as we've been talking about, that you can find a passion if that's something that you like. It can be on a clinical side, it can be on a management side, it can be on whatever. It doesn't matter. But I totally echo what Jim said, is just keep learning, because as you become curious and want to know things, you learn all the time. And I've done a lot of publishing, but I've learned a ton working with people in countries, in being on the ground, and working with the World Bank in different sectors, and trying to pull them together so that everything can make sense for a country. But I think that you have to go in the direction that really interests you. And the advantage of healthcare is there's almost something for everyone, and every area and area of expertise is needed. But you do have to keep learning, and your career will take care of itself, because there's a lot out there, there's a lot to do. And we're delighted that you're all so interested. So best of luck to all of you, and hope that this will help you make your career direction decisions.
Both excellent advice, and you know, I already sort of preempted this a little bit in the previous answer. The only other piece that I might offer is like, with the curiosity and the learning, one piece of advice I give to a lot of my mentees and to my team is just try to read as widely as you can. So that could be whatever field you're really interested in. Know the literature there, try to focus on it and understand what's going on there, but also just read more generally. It's impossible to like be on top of all of the world's literature, obviously, scientific or otherwise. But I think that increasingly trying to expand your own horizons, getting exposure through colleagues, through friends, family, and then through this just intellectual enterprise of just trying to see things from different perspectives, I think is one of the most nourishing elements of all of this. And to Maureen's point, I couldn't agree more. It's just fun. Like these are like, if you come with the curiosity and openness, you'll just have a lot of fun to learn and to meet other people. So thanks again for joining us and hearing about our experience.
So thank you, Maureen, Andrew, and Jim. You guys were absolutely phenomenal. We all learned so much from you. Thank you for your brilliant insights and perspective today. I'm going to bring us home, because I think you shared so many thoughtful insights. And I think where we started the conversation was really around being in this global pandemic and how it amplified both gaps and opportunities. And I think the gaps that all of you shared were really important ones. One's around the inequity that COVID has exposed, weakness in infrastructure and systems, and also weakness in decision-making mechanisms. But I also think that was what inspired me the most of today's conversation, is the enormous opportunity we have ahead of us. And I want to touch on 3 insights that I gathered from all of you, and I hope I capture it well. The first one is really around an interdisciplinary approach and collaboration. And this is going to be incredibly important for solving the complex challenges around global health. And this does include, of course, the importance of public and private sector collaboration. The second insight we heard a lot about today is the power of digital and tech to really scale and solve these problems, but us all being mindful of how we build this technology to make sure that it's deployed responsibly and in partnership, and also that we are mindful of equity as we deploy these. And the last insight I want to touch on is the importance of bringing humanity to everything that we do. So Jim, Maureen, and Andrew, I think what was so clear and palpable about how you think about public health is that you're all very people-centered, and you bring a lot of humanity to what you do, a lot of humility as well. And what I mean by humanity for our audience is really about connection, about empathy, and really understanding the needs of the people that we serve. And I think about spending time with people and communities, as I have as well. And I love, and to really hear their story and their perspective. And I really love this quote by Brene Brown, which is, "Stories are data with a soul." And my hope for all of you is that, you take these insights forward, and that we all continue to bring immense humanity to innovation in global health. So I just want to thank all of you for the opportunity to moderate today. It's been an absolute honor. To our panelists once again, and I'll hand it back to Malik to bring us home for today.
Perfect. Thanks, Natasha. So, I mean, first of all, I just wanted to reiterate just a big thank you to our panelists and to Natasha for what was just an absolutely thought-provoking discussion. It was extremely rich, and it was wonderful to see as well the different learnings and perspectives you brought from around the world. So thank you once again. Before we wrap up, kind of a couple housekeeping items. So some of you will have been selected to attend breakout rooms, and so that will be happening at the end of this call, and you'll have received Zoom invites, I believe yesterday, the day before. But please message us if you haven't. And I'll just hand it over now to Paul Caderio, who's a board member at U of T, just to share a couple of sentences of final thoughts, and then we'll go to the breakout room. But thank you all once again for attending.
Thank you very much, Malik. And I've just been asked to say a few words at the end. This has been an outstanding event. And if I go back to what Aleph said as the goals for this morning, that's actually a good place, and I'm going to say fully achieved. We've had a remarkable insight into global health, from the patient to the provider to the policy to the innovators. And you don't often get that. And our panelists this morning have brought a perspective that reflects their own backgrounds, not only as individuals of tremendous experience, but also for the organizations that they've worked for and that they work with. The Bill and Melinda Gates Foundation has set new standards for global philanthropy, because it's not about giving money, it's about picking the problems and figuring out what the best way into them is, and learning, well, putting in competition, learning what does well, what does best. The World Bank is where Maureen comes from, and where I come from, is a university that lends money, and realized rather later in its time, it made it explicit that it's not so much the money that makes change and makes progress possible. It is the advice that is adopted and adapted by the clients that we serve. And Jim from BCG, as a representative of the global consulting industry, brings the ability to work for many clients for money, and also to bring that learning and that experience across borders and back into the philanthropies, and we hope into the international financial institutions, as well as the World Health Organization and others who have been involved in making advances in global health, everywhere from reproductive rights to, as we face today, the global pandemic. The second thing that we look at is the role of innovation. And while the conversation was on, I went and looked up something that I have on my refrigerator. Skepticism is a virtue. I'm not sure how that comes out on Zoom. I've never pulled up a postcard in front of my screen. Innovation is something that we have seen in spades, and we read about it every day, and we see it on television during the pandemic. The origin story of the BioNTech Pfizer vaccine is about innovation. It is about skepticism. It is about trying over and over again, and it's about global contacts. And the depth of the researchers who worked on this for years, and the breadth of the academic scientific community, as well as their commercial partner, Pfizer, and then Moderna, should be an example of how innovation happens. It's having that question and being curious and figuring out one morning, I think I have an answer. Lastly, the approach of interdisciplinarity is, I hope, goes without saying. And I'd just like to remind everybody, as an engineer, that those machines and those supply chains and those wonderful airplanes that bring us vaccine and truck it around and keep track of who gets it, and indeed make it difficult to make an appointment. Engineers brought the world a lot of that. And there's a role for everyone. You don't have to be an economist or a health expert to do something in the great innovations and the great challenges. So thank you very much. I want to also thank the University of Toronto and BCG for their lead role as sponsors of Global Spark. And I think the last event where I shook someone's hand was after last year's Global Spark event in Toronto. I look forward to doing this in person with you again. Thank you.